estrogen was unavailable in this hospital. But on hospital day 2, they had required it from an outside hospital. So she had received IV estrogen for a little less than a day with also no improvement in her symptoms. And the patient continued to have active bleeding with symptoms and a downtrending hemoglobin that was not responding to the packed red blood cells. IR had been called, but they were unavailable and they had declined essentially a UAE, saying that the procedure could be done possibly the following day. And so on hospital day 4, the patient had gone to the operating room for a total abdominal hysterectomy, or a supracervical hysterectomy, I should say, and bilateral salpingectomy. The case itself was uncomplicated, and her hemoglobin had improved postoperatively, and she was discharged. So my teaching point that I was going to make for this case was that in several institutions, medical management can be a great first step, but eventually there needs to be a decision on when we should take a patient to the OR who is actively bleeding and possibly hemodynamically unstable. She was not responding to the TXA nor the PRBCs, and she was taken to the OR, I believe, a little delayed from when maybe we should have taken her. And IR sometimes is not a solution for many patients or many institutions. And so we have to be kind of mindful of that and try to see how to actually go to the source and stop the bleeding. So that was the take-home points for my case. Any questions?
Did the patient on final pathology have some unique thing that was the reason why she did not respond to medical management?
She had multiple leiomyomas, secretory endometrium that was seen.
I see that Dr. Ayub has her hand up.
Was there consideration of taking the patient for a DNC, which is a management option for acute abnormal uterine bleeding?
There was no consideration at that time to take her for a DNC. There was consideration possibly to take her to the operating room a little sooner, but that was not feasible based off of the circumstances at that time. But yeah, I do agree that a DNC could have been also offered and suggested for the patient. I think in her case, because she has a fibroid uterus, the DNC is not a long-term solution for her, but possibly an acute management option for her.
Great, Devika. Well, thank you very much for that excellent job.
Thanks, everyone.
All right, so we can take a pause for just about 60 seconds, and then we can get going with grand rounds. And the speaker can go ahead and start sharing.
Morning, Dr. Grobman. I know you're there.
I am here. And you should see my screen.
We do.
Oh my God. So
Amazing.
exciting.
All right, well, since everyone is ready, Dr. Murta, whenever you're ready, you can introduce our speaker.
So it is a real honor and a pleasure to be able to introduce Dr. Bill Grobman, who's a long-term MFM colleague and someone I consider a friend. We'll see actually whether or not he agrees with that. We'll leave that up to Dr. Grobman to confirm or not. It really is an honor to have you here, Bill, and I'm so grateful that you've taken time to talk with us this morning. Just for some brief background, and I think his CV is 143 pages long. I was going to read through the whole thing, but I won't because it won't give him any time to speak. But he did his med school training at Harvard and his MBA at Northwestern, residency fellowship, and then joined the faculty at Northwestern, where he was until 2021 when he moved to the Ohio State, emphasis on the. where he was vice chair for clinical operations and director of Women and Infant Service Line. Dr. Grobman has had an incredible career and continues to be incredibly productive. He's a member of the National Academy of Medicine, a really important honor. He's been in multiple leadership roles in all of our societies, SMFM, the SMFM Foundation, ACOG. He's been on the board for all those different things. He has 522 publications, and the list of honors and awards just go on and on and on, and I'm not going to go on and on and on. I think the impact that he's had in his career on our fields really cannot be overstated, and he is a real scholar and a friend. And Bill, I'm going to turn it over to you and stop talking. I'm really delighted to have you here this morning to talk about the ARRIVE trial, interpretation, and implications.
Thank you so much. It's a very kind introduction, and I can completely confirm that I am Dean Mercer's friend. It's probably the most important part of the talk this morning. And it's great to be here in the post-COVID world. And I'm really excited to be able to talk about the ARRIVE trial. And let me just start by saying I'll talk about the ARRIVE trial, but really the specifics of the trial and are going to be the least beefy content of my talk, and it's going to be more about thinking about the trial through the lens of critical literature review, how things get interpreted, and the implication for those interpretations. And I'll use the ARRIVE trial as sort of the pivot for that, because it's one I'm familiar with, but hopefully it serves a more general purpose. And now I just need to, there we go. So, the obligatory disclosure slide, of which I have none. And so I'll start just by saying, and I don't know the practice there, and I don't know the kind of prevailing ethos or thoughts. But I will say that when I was growing up in my obstetric life, it was a given, like in a way that I don't know that I can fully express to people at this point in time, that induction causally led to cesarean delivery and a host of other adverse consequences for the pregnant person and the offspring. And I would say, to the point that I don't think it was really discussed as to whether or not that was true or not, any more than the kind of idea that we breathe oxygen is. And the reason for that, in retrospect, I think it's really interesting. And so I think this is the first point I'd want to make to you, which is that was founded universally on retrospective cohort studies. Now, there's nothing about the retrospective cohort study actually that's the problem, but it's how the retrospective cohort study was done. And only to say that something like this could have never been done in a randomized trial, and actually didn't need to be done in a retrospective cohort study. What was done for, I think, a variety of availability biases. And that's to say that, well, it was done like this, where you see the chance of cesarean delivery based on a comparison of two groups. In one group were people being induced, could be for medical reasons or no apparent medical reason. And then in the other group, the comparison were people who were not being induced, but by not being induced, it was the comparison group was meaning spontaneous labor. Spontaneous labor often at the exact same gestational age through multivariable analysis, adjustment. And so you got this result, which was the result that was gotten over and over and over again, which was that if you compare people at the exact same gestational age who are undergoing induction versus spontaneous labor, the chance of cesarean and some other bad things, I'll take, by the way, an unnecessary cesarean to be a bad thing, as double. So the risk, you get a twofold-ish, maybe 50% increase, but a notably increased risk with induction. And it was on the basis of this that it was thought that induction increased the risk of cesarean delivery. Now, no matter what your thoughts are about induction or cesarean delivery, I do want to point out that this isn't like a bias or a slight problem with confounding, or this is a fundamentally methodologically incorrect way to evaluate your a strategy. Because one is a choice, induction, and the other is not. And this is not specific for this. This is for any decision you're making, you would compare the actual two decisions that you have. You wouldn't, for example, choose the goodness or badness or consequences of trial of labor after cesarean by comparing people who chose to undergo a trial of labor by individuals and their consequences who had a repeat during labor, right? Because the choice is not repeat during the choice is having the trial of labor and then all the things that could happen after that. So bottom line is this is just incorrect, not a slight bias, and it gives really no insight at all, I would say, into the consequences of induction and the choice to undergo induction. And indeed, epidemiologically, although again, as with the study I just showed you, in no way telling you what the right answer was, there was very clear evidence that week after week, no matter what the way that labor started, whether by induction or spontaneously, the risks of cesarean, here are 3 studies by Aaron Coy and Yvonne Chang, people who were actually very fundamental in having the rest of the obstetric society rethink how we were understanding induction of labor. From 39 to 40 to 41 weeks, an increasing risk of cesarean delivery as you deliver at those later gestational ages. And if your thought experiment was, wow, if I deliver at 39 weeks versus 41 weeks, then my risk of cesarean delivery is quite a bit lower. Now, again, that doesn't tell you that delivering at 39 weeks by a medical intervention would be better, because then you incur whatever potential risks of the medical intervention exist. But it at least sets for you the idea that, and I'll call it expectant management, or not being induced, you can call it continuing pregnancy or whatever grammatical construction you want, may not be automatically better because you incur other risks as gestation goes on. And this is just as those other studies were incredibly consistent. I don't know of a study that had sufficient numbers of patients where you compare spontaneous labor to induction at the same week that shows that does not show that induction is associated with an increased risk of cesarean in that comparison. I don't know of any study that has sufficient number of patients that doesn't show this trend for cesarean or hemorrhage or peripartum infection or 3rd or 4th degree laceration, or in this case, severe complications for the neonate. Here, birth trauma, seizures, intracranial hemorrhage, sepsis, meconium aspiration, RDS. And you can see going from 39 to here 42 weeks, that there's a significant increase from 1.8 to 3.8%. That's certainly statistically significant. They said many, many patients in this study. And you might say, oh, it's not such a big increase. It's only a risk difference of 2% about. But on the other hand, I would say to you, and again, if we had sort of magic and one could deliver at 39 weeks instead of 42 weeks, and you imagine that there were no other consequences, and you ask, well, what is the number needed to treat to then prevent a very significant adverse neonatal outcome? I think any of us, any day we're on labor and delivery, didn't have one of these things, we'd be happy. It's the number needed to treat of 50. Now, again, I want to be extremely cautious, and in how I'm relating that, I am not saying that this tells us what that consequence will be, but I am saying that this tells us that automatic belief that induction compared to not expectant management is going to lead to greater harm is not clearly true from the epidemiology. That, of course, needs to be supported or investigated from further observational studies that are done appropriately and correctly, which I'll show you right here, as well as ultimately randomized trials, because I'll just put forth that we wouldn't want to, I would consider changing approaches to induction is a major difference in how we care for people, and that we really want to make sure that we get that right. And that although observational studies are excellent and can provide data that supports undertaking a larger trial, it would be rare that we would want to change obstetric practice on their basis alone. Here is, I think, two properly done studies, cohort studies where they looked at people who were undergoing elective induction at 39 weeks versus those who were expectantly managed beyond that point. So some went into labor at 40 weeks, some needed to be induced at 40 weeks for preeclampsia, and so forth, and then compared their outcomes. The Chang study is a study in the United States. The Stock study has a lower, and this is the chance of cesarean delivery, has a lower chance of cesarean delivery, both because it's done in the United Kingdom and because it was where the Chang study was only nulliparous individuals, the Stock study was mixed parity. And I will say, as this slide implies, this question is most relevant in some ways as the biggest health implication for nulliparous people who have so much of a higher chance of cesarean delivery than someone who's had a vaginal birth before. And so the consequences of an increased risk are in terms of, again, of that risk difference are enormous. And you can see here that the results are incredibly different than the observational study I showed you before. Whereas now the expectant management group is in the blue, the induction of labor group is in the yellow, and you actually see the induction of labor group has a lower chance of cesarean delivery, 10% lower, that because these studies had thousands of people was statistically significant. And I'd say two things. You might say, well, 10%, that's not such a big difference. I would say, if you believe what I said at the beginning of the talk, which is an unnecessary cesarean, a cesarean that can be avoided, is a good, then I would say a 10% risk reduction is a not insignificant thing at all. And that if we find any intervention that can reduce the chance of cesarean delivery, that's an intervention we'd at least want to countenance as something to offer or to be considered as part of our, not the only tool or option available to us by any means, but one we wouldn't want to dismiss. By the way, it's not just maternal outcomes. Here's a couple of perinatal outcomes. And I'd point out to you that sometimes we have interventions where the maternal and the perinatal outcomes are in conflict. Intervention for preeclampsia. You always benefit a pregnant person by delivery as soon as possible with someone who has preeclampsia, but that's in opposition potentially to the outcomes for the perinate. Here, it seems that an intervention like induction of labor with no other reason at 39 weeks versus expectant management improves that outcome for the neonate, both in terms of meconium aspiration syndrome and perinatal mortality, I think an outcome no one would say is not a primary outcome, and reduces it significantly by 70%. And so I think you'd say, like I said, well, those are only observational studies, rife with the biases that may come with them. What about randomized control trials? And the first, I won't go over all the randomized control trials, although I will point out to you that any properly powered one has never shown that induction, that I am aware of, has ever shown that induction compared to expectant management at full term increases the risk of cesarean. Has never shown that. But I want to point out to you this one by Hannah, which maybe you don't think about very much anymore, but I think you probably should. It was done in 1992. Again, I don't know the practice there, but I'm going to put forth that if someone comes in at 41 weeks with no other indication for induction, I'm going to put forth, but someone can disabuse me of this notion, that is not considered an elective. I'll even use the word elective in air quotes, but is considered a medical indication. What I want to point out to you that whether it's 41 or 42, that makes the implicit acknowledgement that gestational age alone is considered a reason, a medical indication for induction. We can argue what the best gestational age is, but the concept that gestational age is used as a hinge on which to understand risk and benefit, then I think is unassailable, because whether or not you're someone who believes it's 42, you acknowledge that there is some gestational age, even if that gestational age, 42 weeks, was picked completely arbitrarily and never been shown to be better than earlier gestational ages, that there is a gestational age which is considered an indication for induction. 41 weeks in 1993, when I started practicing, certainly where I was practicing or participating in obstetric care, was absolutely considered an elective induction. That there was no medical indication, and people who were brought in for that, the question was, nulliparous people particularly, the question was why. You're only increasing the chance that they're going to have a cesarean delivery rather than waiting another week, because of course the data that I showed you earlier. Hannah in Canada did this multi-center trial of over 3,400 people and showed indeed expectant management was not associated, you didn't lower by avoiding induction your chance of cesarean. In fact, you increased it, because in this randomized trial of people at 41 weeks, those who were induced, again, at that time considered electively, had a 20-ish% lower risk of cesarean. So for all those years, that impulse to avoid induction in the quest of lowering your chance of cesarean was actually it was counter helpful and counterproductive, because if you believe in this large randomized trial done in Canada, it actually was doing the exact opposite. We'll fast forward several years when Kate Walker and her group in the UK looked at over 600 people over the age of 35 years, randomized to now induction with no other indication, low risk people at full term, 39 weeks, versus expectant management. This study was powered to cesarean delivery. And those who were randomized to induction of labor had a slightly lower but statistically insignificant difference in risk compared to those expectantly managed. Now, again, by this point in the talk, you might look at this and say, well, like, wow, that's not a very big difference. But again, I would point out to you, coming into this, everyone had the strong belief that induction increased by half or doubled your chance of cesarean. So the idea that actually there's no difference at all in this study, I think is still a very powerful idea. And if that's true, reorients us to when I was starting, induction was truly prohibited. If an individual wanted an induction at 39 weeks for this, that, or the other reason, she would be unable to obtain it at the hospital where I was working, because it was prohibited because of the idea that it was an elective intervention that only led to harm. Here, of course, that I would say would reorient us if what we're really thinking about is person-centered care and trying to figure out what is going to be the best for any given individual in terms of their birth experience. That leads us then to this randomized trial called the ARRIVE trial, sponsored by the NICHD, looking at and a larger trial, 10 times larger than the Walker trial, because it was powered to perinatal outcome. Not because in any way, shape, or form the maternal outcome is less important, but because the adverse perinatal outcomes are so much less frequent that if you power a study to an adverse perinatal outcome, you pretty easily capture so many of the adverse maternal outcomes that occur in any potentially occur in any delivery. I won't go over great detail about this other than to say it's a randomized trial. The inclusion criteria I do think are super important because it speaks to generalizability and applicability, which is that it was nulliparous individuals with singleton gestations who had reliably dated, just like the dating we would use to schedule a 39-week scheduled cesarean if someone had an indication like a prior cesarean. And of course, no contraindication to vaginal delivery. And then someone who is low risk. And what does low risk mean? Sometimes that's been talked about a little bit like, low risk, but like there was a editorial once from a group in Italy, and they said, well, our patients are more low risk than yours. there's more obesity in the United States, and here you included people who had obesity. And I would point out to you that this was a pragmatic trial, and low risk meant something very simple and easily operationalizable, which is that there was no accepted medical indication for delivery prior to 41 weeks. And I think, at least in this country, everyone's aware that BMI per se is not an explicit, and certainly in the mid 2010s was not an explicit indication for delivery at 39 weeks. Someone who's 36 years old was not an explicit indication for delivery. It was now someone who has chronic hypertension, that is an explicit indication for delivery at 39 weeks. And so that person was not included. But the rest of people who were included were people who had, and low risk simply means that they were low risk enough, even of course people have slightly different risk profiles, that their risk was not high enough that it led to an accepted and consensus opinion that induction was better than not induction at 39 weeks. Randomization was simple. You either were randomized to a group where there was planned induction in the first 4 days of the 39th week, and expectant management was just to forego elective delivery or delivery prior with no other indication prior to about 41 weeks, giving a few days for people to have some flexibility, as again, this was pragmatic, as absolutely I think occurs on any of our labor and delivery, and then be delivered by 42 weeks and 2 days, which I don't think was a stretch to ask people to do that. And I suspect at your institution, very few people are delivered at or after that. The outcome was a composite and I won't read these all, but I think if your eyes glance over them, you'll see they're all crummy things, again, that none of which you want on a given day: seizures, perinatal sepsis, meconium aspiration syndrome. And then, as I implied, there were many maternal outcomes, of course, looked at as well, cesarean delivery being the primary, a priori defined primary focus, given all that had been written about induction in that context before, but of course, looking at many of the other complications that people have. And then I'd want to point out the two things on the bottom, which I think are really important, and which are patient-reported outcomes, because we can say whatever we want from a clinician perspective, like, oh, cesarean delivery is lower or no different, or oh, chorioamnionitis is no different, and just fill in the blank. But at the end of the day, this is an intervention in a really quite special time in a person and family's life. And so it's really important to know, if we were to say to them, for example, induction doesn't do this, or induction does this, and it were to be an option, we also want to be able to know to some degree for people who participated in a trial about labor induction, whether or not it's what it means for their labor pain, both overall and worst pain, measured by a validated scale, since there is at least discussion or talk that oxytocin or induction per se increases labor pain. And also, what does it mean for satisfaction or sense of control in a birth process? And this was assessed by something called the labor agentry scale, both after delivery and then a few weeks later, which was developed in the United Kingdom. That's why it has a word like agentry, which is not one we use, but is sort of equivalent to agency, and was developed by midwives and validated psychometrically. So the typical table 1, just to show you that all the characteristics in the two groups, about 3,000 in each group, were the same. But I really point out to you this idea that 2/3 of the people in this trial were, and this is another important part of this trial that had not been done before, people had their Bishop score evaluated at the point of randomization, at the point of baseline, and about 2/3 of the people in this study had an unfavorable cervix defined by a Bishop score less than 5 at the time of randomization, which was only a few days before the induction itself, if that's the arm they were randomized to. And so what were the results? The primary perinatal outcome that I showed you was 20% lower among the people randomized to induction. I will point out to you that the p-value was 0.049, but a priori, given that we had chosen to do a interim analysis, and that interim analysis, which I can talk about in the question part, spends a little bit of P rather than being 0.05, the statistical significance threshold was 0.046. So this does not reach statistical significance, meaning the way we would formally express this is that there was no statistical difference between the two groups. And that, of course, doesn't disallow you from having any insight. It's not like it, let's say it was 0.045, we wouldn't be like, oh, what an enormous, benefit this is. And at 0.051, we'd be like, oh, there's like no difference at all. You can look, for example, at the confidence interval, which the nominal confidence interval doesn't cross 1. And you can say, look, I may not be able to statistically, with a high degree of confidence, know that induction of labor compared to expected management reduces the chance of an adverse perinatal outcome. But I can know that there's actually a reasonable probability that it does, and a very good probability, like a exceedingly good probability, that it does not worsen that outcome. On the other hand, within the individual components of that composite, the need for significant respiratory support was significantly lower among the individuals randomized to induction of labor. And that did reach statistical significance, and most other things were in the direction of benefit. Cesarean delivery was also a point estimate lower in the induction of labor group, 16% lower specifically. So another way to say that is induction of labor with no other indication at 39 weeks compared to expected management reduced the chance of cesarean delivery by 16%. And this was statistically significant and highly statistically significant. It also, perhaps not surprisingly, reduced the chance of hypertensive disorders of pregnancy because, as we all know, the chance of that is so much lower once you are no longer pregnant. And things that have been attributed to induction before, like a greater risk of infection or a greater risk of hemorrhage, were indeed not were not increased either statistically significantly or with any real evidence of that in terms of directionality. With regard to patient-reported outcomes, whether it was labor agency score at any time after delivery or 6 weeks after delivery, or worst or overall labor pain, all were statistically significantly better in those randomized to induction of labor. And then something I'll come back to is, and these p-values are interaction terms, asking the question for any of these things that you see before you, self-reported race ethnicity, because we know of all the disparities that exist with regard to care, favorability of the cervix or ripeness of the cervix, body mass index, and maternal age, two characteristics that have been associated with the chance of cesarean, as well as adverse perinatal outcomes, asking the question, do those characteristics alter the results that I've just shown you? Does it mean that the chance of cesarean delivery, the reduction in cesarean delivery is any different? The relative reduction in cesarean delivery is any different for those with a favorable or unfavorable cervix, or the primary perinatal composite? And the p-value, as you can see, for all of these things is not significant, meaning the answer to that is no. The results I showed you for the overall trial are equally applicable for differences, unfavorable cervix or favorable cervix, and you can apply that for any of these characteristics as well. I'll also say after this, there was a post hoc analysis done by the delivery provider, midwife, or physician, and there was also no difference in these outcomes. So what are the concerns that have been expressed? And I want to sort of deal with those, not really as a way of rebutting them just in the context of this trial, but as a way of understanding these concerns, using this trial as a lens, but using the trial to think about how you would or would not use them in the future, and when they are and are not applicable or rightly used. So here are some of the concerns that have been expressed in either talking to me or written in editorials or whatnot. So and I'll sort of go from smaller, not in magnitude, but like individuals, to sort of larger concepts. So one is like the population's not identical to that at our institution. As a like even in a country or at our place. And if we were to do this at our place, it would be very different. That's sort of an equivalent to our patients are different. My patients are different. And maybe expressed in a slightly different way to say, maybe it's true for some people, but it's not true for people who have particular combinations of characteristics, and I could have some insight into what those combinations will be. That's one. Even if you don't believe that, then you'd say, but this was done in a trial. It wasn't all university hospitals, but if we did this at our place in regular care, it's just not going to hold up. The next one would be, even if you believe it will hold up, is, well, it's going to be more resource intensive, and so we wouldn't want to deploy it. The next would be, is even if you don't think that we should be deciding the things we offer to people based on money alone, that we don't really know the long-term outcomes. And the final one is, even if you believe that there's no good evidence that long-term outcomes are different, and indeed delivery at 39 weeks is completely consistent with other choices we make for pregnant or recommendations we make, I should say, for people who are pregnant, and choices they make with regard to timing of delivery. You might say that someone might say, oh, this is just like a fracture with what we knew before, and it's really different, so we'd never want to change our beliefs based on one trial. So let's deal with those one by one. The first one is that this population is so different at our institution, or my patients, or at our place, and so it's not generalizable. And what I would tell you, and I'll read like a short statement from this article by Collins in the New England Journal of Medicine, just to give you a reference so you realize it's not just me saying it, but it's someone else saying it, which is, that is a misunderstanding of generalizability. So the proper understanding of generalizability, and when it is and should be used as a criticism, is if someone said, for example, I have no idea if what you found in this trial is true for people who've had a prior cesarean birth. Like, there was no one in this trial with that, and so we have no idea about that. Or there was one person in this trial with that, and so we have no, which there wasn't. There was no one in this trial with that. But we have no, that's in the Walker trial, there was only people 35 years or older. So you don't really have the ability to know if it would be applicable to people under the age of 35 years. But when the trial includes a large and diverse population across many domains, what isn't a way to express generalizability is, the mean age in your trial was X, and the mean age at my institution is Y, and so it won't be the same. There is only one condition under which that would be true, which is that, so it's not that the assumption is that the patient population is representative of all patients, i.e., if my mean age is one thing and yours is another thing, it's different. It's that if the proportional effects of the treatment studied on each specific health outcome are different, I'm now paraphrasing, then there's a reason to believe that the results won't be applicable. So, for example, if age matters in the outcome, and my population has an age of X and yours has a population of Y, then it really may be different, and it may not be generalizable to your population. But if age doesn't matter, and our mean ages are different, or our proportions of people over the age of 35 are different, then the fact that our populations are different makes no difference, and doesn't let you say with validity that generalizability is a problem. And I've shown you on the table 1 that this was a widely diverse population. It was not restricted to any large degree with regard to things like age. It included people of different insurance status, prior pregnancy, like lots of different things. And I also showed you that some of the things most associated with the risk, for example, of cesarean delivery and adverse perinatal outcomes, and that have been shown to have disparities in those things, also were not associated with differences in the proportional effects of the intervention. Also, this idea that as an individual clinician, someone can have insight into there are certain combinations of characteristics that I will be able to discern that don't mean that these results will not hold for, has never been able to be validated. Here's an article by Bob Silver and a group looking at, and I won't get into the details of this, although again, happy to, just given time, but happy to do it in a question and answer period. And what I would take away from this slide is that at all different characteristics, combinations of characteristics, and you can think of those as probabilities of having a vaginal birth based on those characteristics. Is there any combination of those characteristics at which that quote unquote induction of labor, elective induction of labor at 39 weeks has a lower chance of vaginal birth? This is the chance of vaginal birth than expectant management. And you can see that along all these probabilities representing all combinations of characteristics of individuals, there's no point at which expectant management gives you a greater chance of vaginal birth. You also can't, sort of the converse, you can't get insight from characteristics as to who's is at particularly low risk of having adverse consequences after delivery, like postpartum hemorrhage or severe perineal lacerations or adverse perinatal complications, by looking at patient characteristics and saying these people are so low risk that expectant management really doesn't pose any greater hazard for them. And this is by Dr. El Sayed and colleagues looking at that and seeing that once again, and I'm just not showing you the data, but happy to discuss it, that you can't find combinations of characteristics that allow you to have that insight. What about this idea that, okay, if we put away this idea that you can't really say that this isn't generalizable to my population, and that efficacy is shown, that it's not going to be effective in our population. And that's, I would say, also kind of a tough nut to put forward for a couple of reasons. One is there's just no evidence in actual results that is true. And I'll show you how would we determine effectiveness. Well, we'd ask the question, what actually happens in regular clinical care? And how would we do that is by looking at results of observational studies that document actual clinical care. And so here are 5 observational studies. This is a meta-analysis looking at what happens from induction at 39 weeks with no other medical indication compared to expectant management in actual clinical care, not in trials. And this is several hundreds of thousands of people. And what you see is that induction at 39 weeks with no other medical indication was, in these observational studies, was associated with a 17% reduced risk of cesarean delivery, which I'll just note to you is extremely similar to this, and these are all nulliparous individuals, is extremely similar to the 16% lower risk from the trial. Respiratory compromise, a 29% reduction in this meta-analysis, which was identical to that seen in the trial, and something the trial couldn't study because it could study it, but not in a meaningful way because it was not large enough because perinatal mortality at 39 weeks so uncommon. But nevertheless, over many thousands of people, or tens of thousands, or hundreds of thousands possible, and perinatal mortality, similar, I would remind you, to the stock study, observational study, reduced by induction of labor at 39 weeks by over 70%. So you might say, okay, well, you've shown me, or I believe you, that it's effective, but it's more resource intensive. And indeed, even in this randomized trial, that's true. And what you see, although probably not for as much as you see it, because I think in our mind's eye, we make the wrong comparison, which we established earlier on, which is induction versus spontaneous labor. And again, that's not the comparison to make if you're trying to understand resource utilization. You need to compare expected management to induction of labor. But in this randomized trial, and this is similar to some observational studies that have been done and made that comparison, I think there's little doubt that those who are induced at 39 weeks compared to expectant management have a longer time on labor and delivery. Probably not as long as I think people intuitively expect, because their idea or their comparison in their mind's eye is spontaneous labor, but about 6 hours longer. And that's certainly a thing. Although, even if that was the only thing about resources, and it indeed cost us 6 hours and the money associated with that, I would ask you if that. I would ask you if that reduced if that was would we not be willing to spend that to reduce the chance of cesarean delivery or some other adverse consequences. I would argue that we should be willing to spend money to reduce those things. And in fact, we do all the time. We undertake trial of labor rather than go to a repeat cesarean and incur all the extra time. We say it's better for people to push longer in the second stage because we don't say, well, we don't want to spend that extra time in labor and delivery. And I think that's exactly right. The other thing, though, is even if you didn't believe that and believe that it's just about money, then it needs to be about money. And then it needs to be about money spent in the two strategies, not just money spent on labor and delivery, but money spent the difference between the two strategies. And then actually, it doesn't seem that induction of labor is more expensive because then you don't, when someone's induced, they're no longer have antepartum care, meaning antepartum visits to treat, prenatal care visits in the outpatient, antepartum visits to triage, coming to urgent care, even coming to the emergency room, every now and then having inpatient days because someone's sick. And this is looking at results from the ARRIVE trial. And this is resources used per 1,000 people. And yellow means there were more resources used, or I'll say it a different way, fewer resources used by people who were induced. And you can see for every 1,000 people, more than 1,000 outpatient visits saved, if you will, in the group who underwent were randomized to induction of labor. A fewer inpatient days as well, with this trade-off of longer time in labor and delivery. Indeed, when this has been translated to actual dollars or currency units, and some of this was done in Europe, and it was euros and pounds, whether it was in the HIPPOTAT trial, which wasn't an elective induction of labor, but was induction of labor versus expectant management nevertheless, at or near term, induction was cheaper. It was cheaper in the Walker trial that I showed you. And in Einerson, looking just at ARRIVE participants in Utah, because they have a very detailed cost accounting system that wasn't true in all institutions that participated in the ARRIVE trial. There was no difference in the cost between those randomized to the two groups. So it really can't be said that induction of labor is a more expensive strategy. And it absolutely can be said that it leads to a few more hours for those people undergoing it on labor and delivery. Although, again, I would say, why is that not something we would embrace for an individual who wanted it? If, in particular, if you believe the results of this and other studies that it reduces the chance of cesarean and some adverse perinatal outcomes. The last couple things, long-term outcomes are not known. I completely agree that we don't know the long-term outcomes of the people in the ARRIVE study or really from any of these other studies that I showed you specifically, trials specifically. First, though, I would ask you to reflect on regular practice. Like, for example, do you believe in your regular practice that delivery at 39 weeks causes long-term adverse neurodevelopmental outcomes for the infant? Do you, when you're scheduling a repeat cesarean delivery, do you not do it at 39 weeks because you really want to allow the pregnancy to go on as long as possible to maximize neurodevelopmental outcome for that fetus? Again, I don't know the practice there, but I suspect not. And I think that tells you that in everyday practice, you don't embed this idea that delivery at full term has adverse long-term effect. And indeed, that's never been shown in cohort studies with the appropriate design, meaning people who deliver at 39 weeks versus people who deliver afterward. Here's a study by Erica Werner in JAMA Network Open, looking at math proficiency and reading proficiency. I believe this was in 3rd grade and showing no difference. And this study by Yisma in Australia, looking at individuals at 8 years of age, and no differences in the sort of reading, writing, arithmetic domains. And then the last thing, which is, well, it's just so different than everything that's come before. Like everybody else is, so everything else suggested, and we believe that induction increased the chance of cesarean, and this doesn't, and it's weird, and that's actually just not true. That is that's sort of an ahistorical understanding, and in fact, whether it's some of the studies that I've shown you, the trials that I've shown you, the studies actually very consistently show that not to be true when they're done properly, as do the trials. In fact, the ARRIVE study was not a thing apart. It was a thing that was built upon all the trials and studies that had been done before it. Some actually then have come after. The HANA study, which I showed you, which showed at 41 weeks that induction reduced the chance of cesarean delivery. The HIPPOTAT study, not elective induction, but induction at starting at 36 weeks for people with mild hypertensive disorders of pregnancy. This was done in the Netherlands, and it was a real question there because they were trying to delay in routine practice delivery, even at term, for people who had hypertensive disorders because of the concern that induction increased the chance of cesarean delivery, which they really wanted to avoid. And in the HIPPOTAT trial in the Netherlands, a very anti-cesarean delivery society, I'll say as an overall statement, and that's what's been communicated to me by our Dutch colleagues, actually induction was associated with a lower chance of cesarean delivery that just did not reach statistical significance. It was less than 0.1, but not less than 0.5, and that was because it wasn't powered to cesarean delivery. The Bovane study, where induction actually starting at 38 weeks for presumed or estimated macrosomia, lower chance of cesarean delivery. The Walker study, where I showed you certainly no increased risk of cesarean delivery. And the Winterholm study, done in Scandinavia at 41 weeks, where they had to be stopped early and couldn't even get to assess cesarean delivery because those undergoing expectant management had a significantly increased risk of perinatal death. I'll end by just saying you can believe all of this, but at the end of the day, the devil is in the details, and implementation is incredibly important. This is not about everyone should have induction of labor at 39 weeks. This is about we need to be doing person-centered discussions and decision-making, and that we can't do that without knowledge or the ability to communicate evidence-based medicine when it exists. And we can't do that well if it's not equitable. And so, for example, making this a clinician-based decision and not a person-centered decision would be the wrong way to do this. Just like I believe withholding that option from people is. That's about what a clinician wants, not about what a person wants. And we should be able to, in all of our actions, be having person-centered decision-making. And indeed, if we make decisions about who this is offered to, and by this I mean induction of labor at 39 weeks, or believe that this group would want it or this group wouldn't, or whatever, however you're going to construe that, I would say that's a fundamental inequity that is, and inequities are pervasive in clinical care, and we need to be ever vigilant to be stamping them out. And so certainly this would be the wrong thing to implement this in an equitable way. And then I think we need to be thinking about our L&D organization. I fully hear and understand that, and actually, if you think about it from an enterprise level perspective, given that actually a distinct minority of individuals would even be eligible for this, it is unlikely, even if fully adopted, to overwhelm an organization, even though that's people's sort of first impulse, like the number of extra hours on labor and delivery. And I can go over with you why that will actually be very unlikely to be a thing. But even if it does add some time to L&D, again, we do lots of things that add time to L&D if we believe they are leading to benefit. And in that case, if we believe they're leading to benefit, we need to make sure that our L&D, like the other aspects of our L&D, that we try to organize our L&D such that it is working for our patients and not that our patients are working around the barriers of a labor and delivery. And that means, for example, like how we do ripening in an organization. Does that mean that if in the past we would do ripening on L&D, which takes up a lot more time for something that doesn't need the acuity of an L&D unit, can we find a different way to do that? If before this is going to lead, and we restricted induction of labor hours to a few particular times that made it very difficult for individuals to obtain an induction of labor if they wanted or it was right for them. How do we change our labor and delivery such that we can, so that it is working for our patients? So with that, I'm going to stop and I'll take questions, and thanks for your attention.
Dr. Grobman, thank you so much for that excellent talk. Are there any questions?
Dr. Ebert, may I ask a question?
Yes, please.
Dr. Grobman, thank you so much for a great talk. Also, I think I thanked you way back when, but one thing Dr. Murtha didn't say is that in addition to doing almost everything in our field, I relied on you to take care of a close family member, and you gave her expert care. So thank you again for that. This might be a decade ago. I had two questions for you. Number one is, one thing we always seem to do is, this is different than what you talked about, but we interpret retrospective studies almost as when we find an odds ratio of 2 when an exposure leads to an adverse outcome or a good outcome, that's kind of dogma and we should believe that and it's all good. But there's pretty good data to show that most of what you see in retrospective studies, because of things like publication bias, may not be true. Is there an odds ratio that makes you say, I think this is really true and the prospective trial will bear that out? Or do you not have any guidelines or rules when you're trying to interpret retrospective studies?
Yeah, that's an excellent question. Thanks. I would say a couple things. I would say I have a guideline, but not a rule, because like anything, I think it needs to be in the context of, like I would interpret a retrospective study slightly differently than I would if there was a wealth of other retrospective studies and different scenarios, that were showing the same thing. And certainly if there was any preliminary trial evidence that looked like the same. I think one commonly understood odds ratio is around 2. I mean, you mentioned it, and the concern is just that, in any observational study, there's the potential for confounding, and you can adjust, up the wazoo. But at the end of the day, the chance that you've truly adjusted for all the differences between the two groups is pretty unlikely. And you have omitted variable bias. And so that's really the concern, that, boy, if you have an odds ratio of 9, yeah, there may be some but if you've even remotely constructed the study right, there may be some, slight differences between the groups, but it's unlikely it's going to drag down that 9 to, and assuming there's a narrow confidence interval, to not significant and no result. Whereas if it's 2, which probably means the confidence interval is like 1.3 to 2.5, even in a large study, even with a few baseline imbalances, you could kind of drag that study down to not just a not significant result, but maybe a null result. And so, so I would say that's a useful kind of guideline. But just like fetal heart rate tracing, I would say, it's all about context. Like you probably you want guidelines, but you want to interpret those and what's come before, ultimately what's come after, what the context is, and also how how the study is done. I mean, there are times there could be a 3 or 4, and I would look and I would be like, well, there's so much referral bias, there's so much, other confounding bias. These are completely different population, like that. So I don't want people to think if it's a 4, it's like groovy, and if it's a 1.9, it's useless. But I'll stop there.
Yeah, so maybe I can make one more comment, and because nobody else asked a question to start. So, there's like a great opinion piece in New England Journal of Medicine a few years back to say like unless the odds ratio is 5 or more, maybe you need to definitely back that up with a prospective study. And there's a great graphic cartoon from that article that shows you can pretty much like pick any exposure in a certain group and find that it's related to a certain outcome. So I'm always really wary of those things. And thank you for your really great answer. My second question for you is that I've seen some people say that if we do not recommend an induction of labor at 39 weeks, and I'm sorry if you said this, I might have missed it, that we're committing malpractice, that we're opening ourselves up to lawsuits after the publication of the ARRIVE trial. How do you respond to that? Have you seen any litigation along those lines? And do you think that we are obligated to offer or recommend a 39-week induction based on the strength of the evidence from your trial?
Okay, great question. So, and I actually just want to touch on one last thing you said, which is, because I want to make sure that that what I said didn't miscommunicate your first question, which is, I certainly don't believe that I would change practice ever on like one retrospective study with an odds ratio of like 2.4. I completely agree with you. Like, and in fact, I doubt there's any odds ratio that would make me change practice in a demonstrable way from one retrospective cohort. So I think almost any time we really want to be, particularly if it's a big change, relying on clinical trials. I think it's just even the strength with which I would believe that a clinical trial was worth it on the basis of an observational study. But sure, the higher the odds ratio, absolutely, the better. So I'm going to reframe your question, which is to say that I haven't seen litigation, but it's not, a world I'm immersed in. And I would say, I don't think that, and I hear you, and we all are in an environment with, professional liability concerns. But I would want to say, ultimately, the question to me is, the only reason we should be offering it to avoid litigation is if it's the right thing to do. Like so if it's not the right thing to do and that puts people at risk of litigation, then I'm going to talk from a sort of just an idealist perspective, which is to say, then we're going to have to live with that. There's only one thing we can ask ourselves, and that's to do the right thing. So then what I would ask people, and I'll just ask them to, personally reflect, is, given the data that I've shown you, both historical and in the context of the ARRIVE trial, if we believe in person-centered care, is it something we should be offering? And so, and that's really where I think the question should start and end. I think, and by that I mean, I think people who believe for them in their life, and I would actually say, even if it didn't lower the chance of cesarean, but I can imagine, again, like I was in a fairly restrictive system where people who had what now in retrospect I think was really good reasons to want something, but it was withheld from them because of a patronizing sense of harm, or founded for people were trying to act well, but at the end of the day it just ended up sadly not. I don't know why that would be something that we wouldn't offer to people, and if they had an adverse outcome, I think we would not even from a medical legal perspective, but just say, if that's something a person wanted, just like we should be supporting them if they don't, and they didn't have the ability to avail themselves of that, why was that? And like anything else, I'd want us to look inside and say, did we do right by this patient?
All right, well, we're just about out of time. Thank you so much for those thoughtful answers, and thank you for this excellent talk, Dr. Grobman.
Thanks for having me.
All right, and with that, we'll close. I wish everyone a safe and successful day.